Hi, my name is Andrew Umrod and a warm welcome to CPD Me. Here at CPD Me, at the heart of what we do is build a CPD portfolio that is fit for audit, interview, or just to show off your learning and development that you've achieved over the years. So please sit back, relax, enjoy this fabulous webinar, and we'll tell you all about the great benefits of joining CPD Me at the end of this broadcast.
There's a bit of confusion over this one. So what we've got, this is number 5 out of 4. This is a series of ECGs. This one, we're just going to talk about the rest of the ECGs that we haven't really looked at so far before. Some really common ones that we see, some that we don't see, and just get an understanding. Okay. What have I done so far? So thank you so much for the people who've watched all of them so far. We've looked at the principles, we've looked at bundle branch blocks and Wolf Parkinson White. We looked at the unhappy QRS, which was by far my mum's favourite of 5.1 star rating, and also did the T-wave goodbye. My mum said when she watched it back, so there was a couple of bits she got a bit confused, so she only gave it a 4.6. Today we're doing the others, as you can see, that list we're going to get onto in a minute, and the next one. I'm going to talk about this a lot at the end. Never miss an unwell ECG, the black magic of ECG reading. We're not going to sit here and diagnose it. You're going to look at an ECG and going, that's unwell because of this. I need to do this. That's what I'm aiming to get for. So the plan for tonight, we're going to look at heart rates. We're just going to look at very simple rates. PACs and PVCs. I'm not going to tell you what they are because it's going to explain it in a minute or two. AF, SVT, flutter. The difference between fast AF, SVT and fast flutter, pacemakers, chemical imbalance, and I've just chucked in about 4 or 5 ones in there. Some ones that we do see out there occasionally and people just are like, I don't really understand what this is. So I've just put in some a bit more randoms that don't really slot into anywhere. So rates. When we talk about rates, we will kind of get really het up by this number. So when we look at rates, if someone has a heart rate of below 40 beats per minute, that's deemed as absolute bradycardia. 41 to 60 bradycardia, 61 to 90 normal range, 91 to 140 tachycardia, 141 and above is deemed as supraventricular tachycardia. But I'll always be quite cautious of that because it depends on the textbook you read. And also, more importantly, the context of your patient. And that is really important, and that sometimes gets lost when we stand in front of our patient. So an example being, here's a picture of the Tour de France. The Tour de France is meant to be the hardest endurance competition in the world. However many days, burning 3,000 to 5,000 calories a day. These people are beyond fit. They carry very little fat. They're all muscle and fitness. So to use Lance Armstrong as an example, I know what he did, but when I was studying my cardiology or doing it first time round, Lance Armstrong's resting heart rate was 27 beats per minute. Now, if we were just to go back to this one, that would seem he's an absolute bradycardia and we should do something for him. But actually, under the context of him, that's perfectly normal. And from what I understand, the Tour de France cyclists or these kind of extreme cyclists, their maximum heart rate can be above and beyond what we would anticipate them on. There's a rough estimation of 220 is a maximum heart rate minus your age. But these gentlemen and ladies can get that above that without too much problem because they're super fit. Then also, like putting it back into context, if you look at statistics of heart rates and blood pressure, as you get older, they slightly increase. So actually for someone who's a bit older, a resting heart rate of 80 could be perfectly normal for them. 90 could be perfectly normal for them. Once again, it's all about the context of these patients. And then when we talk about rates, changes in rates can be caused by lots of different things. Simple medication, beta blockers, it's in the name, atenolol, bisoprolol, it's there. Mood. Whether you're feeling low or whether you're feeling excitable, your heart rate can change. Drugs, we're talking illicit drugs from, trying to think, I'd imagine ecstasy and things like that, cocaine, crystal meth, I'd imagine would raise it. Level of alertness, if you're asleep, your heart rate goes down. If you're awake, your heart rate goes up. Exercise, we've already alluded to that, but obviously when you're exercising hard, it will go really high and so forth. Age, we've already talked about, and temperature. when you're cold, when you're in extreme colds and you're starting to shut down, your heart rate will go down. If you're cold, your heart rate may actually increase just to try and get a bit more warmth around the body. So it can actually change depending on where you are. But rate-related changes, this is the bit that we want to have a look at. We want to have a look at some rate-related changes. And we always have to think if it's fast or slow and there's changes in the normal PQRST, is it the change or is it the rate that's caused it? So we're going to go straight in. We're going to look at some examples. Oh, let me put my little cursor on so we can see. So if we look at this top one here. Now, when we talk about PR intervals, so hopefully everyone can see my little cursor here at the beginning of this P wave. PR intervals should be between 3 to 5 small squares, 120 to 200 milliseconds. But as you can see, this is what, 10, 12, 14 small squares. So that's huge. It's absolutely huge. And it's quite consistent all the way across. So that looks like this could very well be a first degree heart block. But not only this, we have a QT. So the beginning of where the Q or the R is, all the way to the end of the T should be up to 480 milliseconds. But this one here actually looks like it's probably just over 500. So now we've got an extended PR interval, and also we've got an extended QT on it as well. And then we look at the next one down. We've got a normal PR interval, a very normal PR interval, an extended QT, so from the beginning there all the way to the end, but actually we've got a little bit of a biphasic bit there. So why? Oh, that's not the screen I want. This is the screen I want. Let's put that one back. So why? I think we just need to use a little bit of noggin. If someone is super fit, so let's just put fitness at the top. If they are super fit and they are squeezing all the blood out of here, and they are doing it so efficiently that the blood is moving down, do we need to worry about the speed of this element here? Possibly not. And then it does a beautiful squeeze on both sides to eject the blood out around the body. And it's squeezing so well, it's just keeping everything nice and tight. So what could that actually give us? It could give us those two abnormalities that we've just talked about. So that's one from there to there. It could give us these two here, just because if this person is fit, as an example, as a very, very simple example. But once again, it's the underlying of why are they bradycardic? Why is their heart rate slow? And then we looked at the second one where we had a normal PR interval and we had a normal QRS, didn't we? And actually it was this bit here. This was the bit of concern. Now, once again, if this person could have been fit, I'm using that as a rough example. So if I was to now just use a small section of that, and this is now just a section of the muscle. If you've watched the previous ones before, we know that we depolarize in this direction, and then we repolarize in this direction. But if they're really fit and everything's just chugging away quite happily, so there's that one, we may still having the normal PQR and S, but actually as it's just starting to depolarize from this bit, it's then actually starting just to repolarize from this side as well, giving us our biphasic. But there's no problem. There's nothing here in the way. There's no blood vessel blocked at either side. There's no nerve ending. It could just be the fact this person is fit. Could be. We're going to get back onto those could be's in a minute or two. Let's just get rid of all this for the next one. Perfect. So when we see bradycardia, sometimes we may see changes like this. And once again, it's the context of our patient and why we think it is. So let's have a look at some changes that we may see through tachycardia. So I've put this one up. Does this meet a STEMI? So ST segment elevation, myocardial infarction criteria, a heart attack criteria? If so, why? Well, let's have a little look. So we look in V1, and this little point here, if you can see a little cursor, I'll just wiggle just here. That's my J point. That's the point that we measure elevation for someone who's having a heart attack. And yes, that is elevated more than 1 small square. That's my local guidelines. I think the national guidelines in chest leads is 2. But in this one, yep, it's still elevated. This one, the J point's a bit blurry, but I would probably take it from there to be safe. Yes, it's elevated. And then when we start going to V4 and subsequent, we obviously have some depression. So in the grand scheme of things, it does look like we're having some kind of myocardial infarction. In fact, let's go on to the next one as well, and I'll come back to that one. So I've put another one up as well. We've completely lost our baseline, our little straight line going across the bottom. I think this could be my J point. I'm not too sure, or this could be a negative T wave. I'm not too sure, but it doesn't look great. If this is my J point here, it's elevated. If this is my J point here, it could be depressed, and so forth. And then when I come around to these leads, I've definitely got some depression. Definitely got some depression. So why is the big question, especially in faster rates, because we see more faster rates than we do bradycardia. Why? Well, it's quite, let me just pop that there. So, it's not wanted. Right, let's quickly draw that again. In fact, I don't need to draw all of it in, so it's fine. So if I was to have my ECG dot here, what that's picking up is anything that is moving towards it or away. And what it's going to do, it's going to take the net of what it means. So if it's moving towards it, and let's just say there is lots of it, and I'm just going to use a number scale of 0 to 100, and there was a 90 net moving towards it. And there was also some electricity somewhere in here moving away from it, and that was only a net of 20. That means overall, I've still got a plus 70 net. Now, why is that relevant for these super fast rates? Well, it's relevant because, let me just get rid of these bits. Perfect. It's relevant because what we may have had is the P wave come down, holds on to it 3 to 5 small squares, come down, and it's starting to whiz round here, and it hasn't quite finished whizzing around here. But then what we've actually seen, we've seen more electricity starting here at the top. So because of that, the net moving towards it is starting to increase. So if we were to draw that first one, and it got to that point, and electricity is starting to move, well, it's not quite right that, but for pictorial, starting to move around it, and we get our deep slope, but then actually we've started to get electricity moving towards it, and it started to get here. We actually may start getting this bit, and then that will give us our elevation line. Okay. So what does that mean for us pre-hospital? What does that mean? Well, is the underlying rhythm the reason why it is going fast, or is the elevation real or not? So we're kind of starting looking about why it may not be real or not. Why have I put the underlying rhythm? For some people out there, they'll probably recognize both those rhythms because we've talked about them before. But something like Wolff Parkinson White or a re-entry right bundle branch block, something of those natures can cause it to go really fast. So what we need to do, we need to slow it down. Now, we can't do that pre-hospitally. Yes, you know, if they meet a certain criteria, maybe I have to do the modified Valsalva maneuver, but we don't generally do that out in the community and so forth. There are some specialist paramedics who may be able to cardiovert patients if they're cardiovascularly shocked, but generally we don't. So when we talk about rates, we just need to always remember that at extreme ends, we may start seeing extended PR intervals. That's more of our bradycardics. ST elevations and depressions, and also T wave changes, including, I've called it, QT in previous ones, but long QTC, doesn't make any difference. So fast and slow variations, are they cardiac symptomatic? Can we think about the cause? If they tell us they've got a Wolff Parkinson White underlying, well, that's probably, yeah, it's probably them. If they are someone who suffers from fast heart, supraventricular tachycardia. We're going to talk about that in a minute. You know, we've got a cause for their underlying rhythm, but is that the reason why they've got the elevation and depression? However, we go to someone who's got a fast heart, always treat for what's in front, or fast or slow heart. We've always got to treat for what's in front of us. Okay, it's nice to have this good underpinning knowledge to understand that, oh, I've got someone who's got ST segment elevation, but actually their heart's 130 beats per minute. Is it the rate or is the elevation true? You're going to go down the elevation route, because if it's the rate related, once we slow it down, we've solved the problem. If it's elevation and we don't treat that accordingly, then that causes a whole world of pain for our patients. If it's just slowing down, that's the easy bit. So premature ... contractions is what we're going to talk about next. We're going to talk about atrium and we're going to talk about ventricles. So on previous slides, I think it was the last one, I think it was on session 4, maybe 3, we looked at this one. And the reason I wanted to put this one back up is when we talk about action potential, the heart muscle has the ability to fire off of its own accord. It has this, so as we see it here, this kind of minus 90, but it wants to be up here. Any cell can do it. But what we rely on the neurological pathways in the heart to fire off. But every now and then, for multiple reasons, we get random parts of the heart that say, whoa, I'm going to fire off of my own accord. Okay, I'm going to do it myself. So let's go back to this. Get rid of all this. Let's do that. I need to draw this a bit bigger. So the blue's the neurological pathway we're all quite happy with. So we all know that when electricity goes from here to here, obviously it does follow through the neurological pathways around the atrium. There's a little Bachman branch over here before getting here, and that will give us our nice P wave. And then subsequently it goes down here, and then we get our QRS and whatever's afterwards. Now let's just say we have a naughty bit of the atrium, this bit just here. And it decides that it wants to fire off randomly. And it fires off enough to be able to stimulate this node and give it our 3 to 5 small squares. And we have our ECG dot here looking upwards. What would we see? Would we see our nice normal P wave? Or would it be a different shape? So when we kind of remember when we looked at P waves right at the beginning, if it was just this from here to here, it should be a spike, but it's not. It is this dome, and that's because the electricity actually moves around all of this, as I've just drawn before, moves around all of that. So because now we've got this direct path from here downwards, are we going to see the same? Well, let's have a look. Let's have a look. So premature atrial contraction, premature meaning early, atrium in the atrium, and overall it is causing a contraction. Now, as we kind of look through this rhythm strip, can we really see anything that's unusual? Well, we need to look at the P waves, don't we? It's in the atrial. We need to look at the P waves. Let's have a little look. So the first one, yep, we've got this nice dome shape. Second one, oh, hello. That definitely does not look like a normal P wave, normal P wave, normal P wave, normal P wave, normal P wave. Oh, and we've got a change in P wave. So we have a change in P waves, and it will be irregular. And I've put most of the time because there's always that random thing that actually the heart may sink a little bit with these. Before I move on, I just want to comment on one other thing about this. Let's just say it is here and it actually fires and connects like this. What would we see from the P wave? So our ECG dot is down here. What would we see P wave wise? Well, positive electricity moving away and then positive electricity moving towards. and then we get our normal. Obviously, it wouldn't be that big. I've drawn it that big just for pictorial, but it's just a concept that sometimes the shape of these can be very, very random. Similar thing. Let me just draw my ECG dot here. Let's just say it was here and it was going across here. If it's not moving directly or towards the ECG dot, we may not see it at all. But the way to find them is obviously we'd do a 12 lead, and I'll bet you they'll start appearing. These random beats that don't seem to have a P wave. Premature atrial contractions. Good. Right. So we've looked at the top part of the heart. Let's have a look at the bottom. Oh, I want that. So the principle's the same, really. I've now got a random bit of heart that fires off. And let's just say this one is going to fire down here. So the first question we have to ask is excitability. Does it have excitability? So if you watch back the previous ones, thank you very much for everyone who has, we talk about almost this DJ. This person up here sets the rhythm, sets the beat, sets the tone, and causes this excitability for everything to squeeze hard and have good contractility to squeeze that blood out. But this little one here doesn't have that at all. So what do we see? Would we see a P wave? Nope, we wouldn't see a P wave because it's not attached. So because that, there's no 3 to 5 small squares. We've lost excitability, so now it is slow. We have electricity moving towards the ECG dot. So is it going to be above or below the line? It's going to go above. So we're going to have a no P wave, slow, which in real terms means it's going to be wide, and it's going to be above the line. So we may end up seeing something like that. T wave, sometimes, most of the time, we may see that. But let's just say it is here. But this time it's moving in this direction. What would we see? Would we see a P wave? Nope, we don't have that excitability from the top coming down, so it's going to be slow, i.e. it's going to be wide. It is positive electricity moving away from it. So now it's going to go down. So what we're going to see, we may see something like that. Well, let's have a look at a better example than my drawings. And here we go. So we've got this, oh, where's my little cursor? We've got this normal PR interval, normal QRST, and then, where's my cursor gone? There it is. Every now and then we seem to get these. And once again, you know, knowing whether it's moving towards ECG dot or away from ECG dot, it's just a bit of geek, really. We just need to know that this here, this random wide beat, is being generated somewhere in the ventricle. That's all we need to know. So we have a wide random beat, and sometimes can actually create a palpable pulse. Now, when I do my teachings to other people within my trust, I say if you see a PVC, premature ventricular contraction PVC, if you see one of them on an ECG rhythm strip, all I'm going to ask you to do is to get your fingers, apply them to the wrist or wherever you're taking a pulse at that particular time, and to see whether they're actually creating a palpable pulse. Because if they are creating palpable pulse, that's good. If they're not, that's not so good. It's not so good at all. So let's move on to the next one, atrial fibrillation. So what is atrial fibrillation? Well, atrial fibrillation is defined by no P waves, irregular, non-defined baseline of variable heights in QRS. So I'm doing these next few slightly different to before. I'm going to show you the ECG, and then we're going to have a look at and see why. So I've put, there's lots of words at the top. Feel free to read them. I'm not going to go over them. It just goes over different types of atrial fibrillation. But down here, as you can see, I've got an example. And as per it stated before, no defined real P wave. It's irregular, wandering baseline, and the QRSs are a little bit variable. This one's actually quite quite consistent, but sometimes may see quite variables. But why? Well, let's have a little look. Let's get rid of these bits. Oh, got rid of that. Right. So what has happened? What is happening? Let's just throw my ECG dot in again. So what is happening? So normally we would have the P wave come down from here, and then that would generate our P wave before our QRS. But for some reason, it's out. It's tapping out. And this could have been just through age, illness. Sometimes people get it if they have an infection in certain places. Once again, randomly, you can get it through fitness. If some people are really fit and their heart rate raises too fast, all of a sudden it stops this node from working. Now, we've already started talking about action potential. Oh, try that one around. Where we have this kind of shape. So this is -90, and that's +15, and we have this action potential. Now, because all of these cells in the atrium want to fire off due to the action potential, it's waiting for the pacemaker, but the pacemaker is not working. The pacemaker is broken. So what it decides to do, it just decides to fire off of its own accord. So we just get all these little bits firing off, completely unsynced, firing off. But every now and then, it's enough to stimulate this. And once it stimulates this, boom, it goes down. So what do we see? Well, we've kind of already started to talk about it. We're not going to see a P wave. Oh, okay. We're not going to see a P wave. That's gone. It's going through this junction here. So it's going to be narrow. And we've got a normal QRST. So all these bits of electricity, they could be moving towards it. Some of them could be moving in this direction. Some could be moving in this direction. Some could be moving in this direction. Some could be moving in this direction. It doesn't really matter. But what we're going to see, we're just going to see this wandering, wiggly baseline. And then we're going to get a nice beat off the back of it. And it's purely because this is not working. Or sorry, this is not working up here. So all these bits are firing off randomly. Okay. And that's what atrial fibrillation is. Fast AF. So for multiple reasons, some of them dehydration, some of them due to the heart not functioning properly, electrolyte imbalance, a few other things. Sometimes a patient can go into fast AF. And as it says there, rates can exceed 180 beats per minute. And it can be life-threatening. It can absolutely be life-threatening. We should treat it as life-threatening until proven otherwise. Okay. I'm going to come back to fast AF in a minute or two. So now let's move on. Supraventricular tachycardia. Lots of long words. I always get a bit confused. So supra, meaning above. Ventricular, ventricles. Tachy, fast heart. Somewhere above the ventricles is causing the heart to be fast. That's what it means in layman's terms. Supraventricular tachycardia. Now, why? Why do we know this? Oh, sorry, we've got this. So rates of supraventricular tachycardia, 140, 280, we're going to talk about those rates in a minute or two. It's narrow complex, I'll explain why. No visible P waves, that's the magic for this one. Because it's normally hidden under QRS or T waves. So here we go. We've got an SVT. Okay, but why? Why are we seeing them? Why are we not seeing a P wave? Well, let's have a little look. Get rid of these bits. So as far as we're aware, this is working. I'm just going to scribble it over. This is what we think it's working. So what we believe is happening, this is going from here, let's change that to red, from here to here. It is holding on to it for its normal parameters, and it is then going down. So let me draw that on. And then we get our T wave. But what's happening for the next beat is that it's actually starting to fire off here and go down before it's actually finished. So what we may see, if we could, oh, let's click on there, is our P wave could be hidden under there. So as soon as that finishes, and then our next beat, same thing. Goes down here, 3 to 5 small squares, so forth. But what may actually be happening is the P wave being hidden under here. I've done that in the magical disappearing one, haven't I? And so forth. So why do we call it supraventricular? So supra, above ventricles. From previous talks that I've done before, when it's being generated from up top, it has excitability. The DJ playing its tunes gives everything its excitability. Once it's being generated from here or below, it loses excitability, meaning everything slows down. So what we see at the bottom, we would see a wider QRS. If it's generated from somewhere up the top, we see a narrow QRS. So by means of the name, supraventricular, we believe it becomes from above the ventricles and it's causing the fast heart. Okay. Let's get rid of them. We're ready for the next one. Supraventricular tachycardia. The underpinning bit is the P waves have disappeared. At the beginning, when I talked about rates, I used that number of 140 because when I teach this in a classroom, that's the number that everyone seems to throw at me, 140, because that's what the textbooks say. But it's when the P wave disappears, that's when it becomes SVT, supraventricular tachycardia. Atrial flutter. So narrow complex tachycardia. Atrial activity can be up to 300 beats per minute, P waves, but there's a less QRS ratio. There's a loss of baseline and there's a sawtooth. So once again, let's have a look at an example. Whew, a lot going on here. Lots and lots going on here. The QRSs. So what I'm going to do, I'm going to say the QRS is at a rate of 100. And then we're going to go for the P waves at approximately 300 as per it said. But what is going on? Well, let's have a little look. Yep, that's on the right one. Good. So what we're seeing, for some reason, up here, up top, it's deciding to fire off repeatedly. And it keeps firing off. And on this one, on the fourth one, it's catching and it's creating our QRS. So 1, 2, 3, 4. And well, I say so on. This doesn't stop. This doesn't stop. So as soon as that fourth one is catched, they keep going, they don't stop. So what we may actually see underneath, because of the net moving towards and away, we may see something like that. We may very well see something like that. So when we see a ratio, it could very well be a 4-to-1 ratio, as it says here, but we only may actually get to see 2, maybe 3 of the P waves, because actually some of them are hidden underneath. But it's because there's a problem here. Now, no doubt the question you're probably thinking is, well, why are the QRSs not going at 300 beats per minute? Well, good question. The AV node wants to work safe. It has a mechanism in place to actually slow down the heart, because what it needs a bit of other stimulus. It needs, say, if you're going for a run, you'd relieve, if you're nervous, some cortisol, some adrenaline, some noradrenaline, some dopamine, depending on what you're doing, and you see them, and it will increase your heart rate. With the absence of lots of those things, it will regulate it and go, whoa, 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 I don't need all these P waves. there's no one else in the body telling me that I need to be doing anything else. So I'm not. So it slows it down and keeps it at a normal rate. But as I said, if we were saying the QRSs were 100 and the P waves at 300, what happens if the QRSs do catch up? Well, then we've got an overall heart rate of 300. And that, unfortunately, ain't good. It's not good. Right, let me just quickly get rid of these bits. Let's just dump the whole screen. So atrial flutter. Yeah, so just kind of already related to that, rates up to 300 beats per minute. That is not sustainable for life for very long for any group of our patients. So we've looked at 3 rates: fast AF, SVT, and fast flutter. And can we tell the difference pre-hospitally? Well, yes, we can, purely by using the small little nuances that I've just talked about each one. So fast AF, a wandering baseline, no distinguishable P waves, variation in QRSs, and obviously it's irregular. SVT, very synchronized going across, no P waves again, but very regular. And we do have this baseline going across. Atrial flutter, fast flutter, we've lost our baseline, but we're still getting this sawtooth. And that's the difference between SVT and flutter. And to be perfectly honest, fast flutter, when it's been going like 200, 220 beats per minute, I think I've only seen 3 or 4 times in my entire career in 14 years. We don't see it very often. SVT, we see a reasonable amount. Fast AF, we see loads. We see it very regularly, very, very regular. So pacemakers, let's have a look at some pacemakers. So this is probably what everyone's going to assume a pacemaker is: a nice big grey box. We have these patients, we have them fitted nicely on the left side of their chest, just under the skin, giving them a nice big lump. Well, not anymore. New pacemakers are getting so smart. So this one hasn't made it to the UK. This one's only, I believe, in America. Correct me if I'm wrong. They're getting smaller. They're almost getting to the size of your thumb. And we're getting to the point where, because we're getting so clever with them, we can actually now start putting them places where they're a little bit more discreet. So if you're like me and I like to wear off the shoulder dresses, I like, if I want one, I want to have it popped just under my armpit. No one's going to really see it. Having one on my chest is quite obvious that I've got it, along with a scar that you may be left. And for this next bit about pacemakers, I just remind everyone I'm not a cardiologist. This is only my understanding of what pacemakers do and how they work and so forth. Okay. So let's briefly talk about reasons for pacing, just so we can get an understanding, because a lot of time we go out to patients, they have no idea why they've got a pacemaker. So they've got some kind of node dysfunction. They've got a heart block that needs suppressing. They've had a heart attack, which we now need to take control of the electrical activity, possibly through damage. They've got a complete heart block, so there's no synchrony between the top and the bottom of their heart. And long QT syndrome. So quite rare. We don't see it very often, but that could be a reason why people have it. And people who just have problems with their heart. And heart failure, where the heart is just giving up, and if we actually stimulate it a bit more externally or internally, we can actually just get it beating just a little bit more. So types of pacing, I've just put this up there for a bit of geek. We have single chamber, dual chamber, and biventricular pacing. We also have external pacing as well. So I can do this, not many paramedics out there in a pre-hospital setting. Air ambulances can do it. But otherwise, it's literally, as you see there, we will attach defib pads to the external part of the patient, and we will, in essence, shock them repeatedly for 80 beats per minute. That's the target that we aim for. I do give my patients some heavy sedation when I do it, because it's not particularly very nice. So types of pacemaker. I'm sure we've all had this. We've all gone out to a patient and they said, oh, I've got a pacemaker. So do you know what type of pacemaker it is? And like, no, but I've got this card. And they hand you this card and it's got all this lovely information on it. And you kind of look at it and you think, doesn't really mean that much to me. Because actually it's quite complex of what they're trying to achieve from doing a pacemaker, about whether they're trying to attach it to the atrium, to the ventricle, where they're trying to do all of those kind of bits and so forth. So it's actually not that simple. Oh, no. So what I wanted to do, I just wanted to have a quick, so just so people can understand a little bit of what they're trying to achieve. So not that long ago, a gold standard would be, this is my pacemaker. In fact, let me just quickly draw on some electrical pathways just so we can get an idea. So this is my pacemaker here. Funny. And what they would look to do is attach some kind of wire and then attach some kind of secondary wire somewhere. And it would create electrical charge from one to the next. Hopefully it would catch on some neurological pathways and give us some kind of beat. Okay. Now, things have definitely started to move on from there. Because what they're going to try and do they may well end up with 3 wires on them. And what it would try and do, it would either try and pace it here, or it may feedback loop from here to know whether it's beating or not. This will give it secondary sensor, and this is the endpoint. So when we have really smart ones and it's atrium, we may have something nice and simple. If it's a little bit more crude, are we going to see a P wave? No, we're not. But we've still got this electricity moving from here to here. So what we may actually see is something just a bit bizarre, something just a bit weird. And this is the reason why when we do a pacemaker, it does look a bit weird, because it's got nothing to do with the actual heart. It's to do with where you know, I like, it can have everything to do with the heart, but also it can have a lot to do with where we've actually attached the wires to them. So when we see an atrial pace, we may not see anything at all. It may look completely normal, because if it's done just before the P wave, we may see the P wave as per normal. If we see a ventricular pace, like if we look at some of these, you can see, I purposely chose this one, this is quite an old one, that we can see this pacing spike before every QRS. And it's giving us this wide beat. And that's because it's not quite following the pathway. It's maybe a little bit slow, but as long as we can feel a pulse, that's what the cardiologist primarily wants, is the patient to have a pulse, to have blood pressure and flow around the body. Demand pacing, though we haven't even started talking about this yet, but as you can see, we've got a normal PQRST, P, and then for some reason, the QRS has not started. So it's paced it and given us our beat. And actually on the second one, it seems to have paced it before the P wave and then paced it again. So this one tells me that there's probably a feedback loop, 3 wires feedback loop for knowing if the P wave's being produced in the QRS, but it's not working all the time. So I get asked this question a reasonable amount. Should we be doing 12-lead ECGs on people with pacemakers? Categorically, yes. Because we don't know what type of pacemaker it is, because sometimes the patient doesn't know what type of pacemaker it is. And actually what we record in our rhythm strips and 12 leads may help them diagnose something later on down the line. So on to the next topic, chemical imbalance. Now, I've put this up here. So we've already started talking about this action potential that I've drawn before and the phases that it has. And I've put the ECG below it just so we can have an understanding of what all this means. But with all this action potential, we have some chemicals in here. So there they are. calcium, potassium, and sodium. Oh, so I was going to go to this first. So let's get rid of this again. That'll do. So if I go back to the iron chart, it's something like that. And that is going to give us our nice QRST. But what would happen if sodium ain't happy? What would happen to our QRST? Well, it would change, wouldn't it? Of course it's going to change. Let's draw it back in. What would happen if all of a sudden our potassium levels was to change? It would change the ECG. And this is the whole point. As long as we understand that if one of these elements is in an incorrect balance within the heart, the ECG will change. Categorically, it will change. Now, what can cause that? Like, I've used calcium as the easy get out clause because we talk about calcium channel blockers. Some patients are out there for controlling blood pressure and so forth, and it has to be quite closely controlled. They have regular blood tests when they first start going on them to make sure they're not imbalancing the calcium. Someone who has an acute kidney injury, if you remember back during the summer, I did the dangers of a long lie. Someone has an increase of calcium and it gets into the myocardium. It can cause them to have an arrhythmia and kill them just from having too much salt. We talk about potassium. People who, I remember years ago going to a cardiac arrest of an 18-year-old girl, and she just ate lots of food with potassium. I think it was bananas she was eating. She was eating, 10, 20 a day, and that increased her potassium. It changed rhythm and put her into a cardiac arrest. I've put these, I kind of stole this. Where's my cursor? I've stolen this one. And it does sort of like tell us what it is down the side. But I don't think we need to really worry too much about what the names are. We just need to worry or understand the changes that we're going to see. And as you can see, like, all of these are affecting the T-wave. There's a normal T-wave. We've got this extended QTC. So when I go to a patient who's taken a large amount of antidepressants overdose, sometimes they don't give me the full amount or the full drugs or the full drug list. A QT is what I'd look for. These hypokalemia patients are, especially if they are moving this way, a very high chance of going into a shockable rhythm. We talked about hypokalemia, a change in actual T-wave shape. I talked about that in the previous session about why that happens and what we should be looking out for. And it's very much to do with this top part of whether they are hypokalemia or not. Hypocalcemia, yep. So we've got, once again, it's longid, and also we've got very short there. And why is that important? Well, the ventricles need to squeeze to push blood out. If they want to squeeze and relax straight away, then they're not going to get enough pressure to come out. So chemical imbalance in brief. Big T wave, long QT, short QT, spreading of the whole PQRST. Now that slide, I borrowed that from someone else. What we may see in some patients, if all of this is just a bit deranged, is a bit strange, what we may actually see, everything's in place, but everything gets longer across it. So as time goes on, that could happen. And some antidepressants can cause that. And actually, similar thing, another cardiac arrest where we got ROSC on this patient. We did the 12 lead, and I noticed this, and I suspected, so we treated it with calcium and I can't remember what the other one, calcium chloride and something else. And by the time we left her property, the ECG was back to normal. And when she woke up 3 days later, she admitted to a antidepressant overdose. So remember, the QRS can also get wide as well. So I was going to put this one in, but someone raised a point about 2 or 3 sessions ago. They want to know a bit more about Takotsubo, death from a broken heart. Looks like a heart attack, but it's not. It is a perfect storm of a catecholamide release and microvascular spasm. And I've put under the bottom one, yeah, underlying left ventricle outflow tract occlusion in a third of case. That's very much a individual kind of thing. But it's the top two, catecholamide release and microvascular spasm. Now, what is a catecholamide release? Well, it's part of your fight or flight response, about your dopamine, your adrenaline, your noradrenaline. You need these as every part of your day-to-day. You need them to function, you need them to raise and lower your heart rate during whatever. But this event is where we have an extra special high amount that doesn't stop. It just keeps releasing, keeps releasing, keeps releasing, keeps releasing, keeps releasing, and actually causes the ventricles of the heart to swell and then pushes them into what looks like a myocardial infarction, and that actually can cause them to arrest. And this is what we see from a Takotsubo. And, you know, I don't normally talk about Takotsubo. And the reason being is that when I talk to people, it's like, is this ST segment elevation? Yes. From a pre-hospital setting, if we are happy it's Takotsubo and we pinpoint it, do they need to go to a PPCI? Well, no, because we know it's not an occlusion. But what if I'm wrong? What if I'm wrong and it's not Takotsubo? What if it's 3 o'clock in the morning and I'm, you know, squinting, it's raining, this patient's outside and I'm looking at it and I've seen depression? I'm not going to sit there and scrutinize it. Oh, maybe it's Takotsubo. It's ST segment elevation. Let's speak to the people who deal with this and let them make that decision for me. Okay. So yeah, and now just some others. Oh, it doesn't look good, does it? It doesn't look good. But I just want you to think, like, here we are at the end of 5 weeks. I just want you to think, all I can see is P waves on here. So let's have a little look. What do we think is happening? Let's just bin that and let's quickly draw another one. Doing this color. So what is happening? Well, we know the P waves are firing off. Boop, 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 boop. Is anything else happening? Nope. The ventricles are not firing. And how do we know? Because we can't see anything. We just can't see anything. Ventricular standstill. It's a ventricular standstill rhythm. So it's the opposite, isn't it? This is the absolute opposite of what we've just looked at. Once again, if it's not going through this junction, it's going to be wide. Is this wide? Yes. So somewhere along here, it's firing off and it's doing its bit. It's going down the pathways and it's causing these kind of slightly wide with our T wave. Is anything happening here? No. Well, this one was ventricular standstill. This one's atrial standstill. Ooh, now what if I was to say to you, this patient is conscious and talking to you? I've had it happen more than once. Trust me, they're not talking to you very long. I'm going to tell you what it is and I'm going to explain what it is. Toussaint de poix. It's Toussaint de poix. So that is French for turning of the points. So what is happening? Well, the electricity is literally whizzing round it. So if I was an ECG dot and I was here looking at this, as it's moving towards me here, I get this nice big bit. As it's kind of going around the side, it gets smaller. As it goes around to this top end, it may get a little bit bigger. Towards me, it gets bigger again. So we have this big, small, back to big, and very little segments here. Toussaint de poix. As I say, they're not going to be conscious very long. They're not going to have a pulse for very long. So as soon as they become unconscious, we're going to be shocking them, but they could be conscious. And, you know, they could be conscious for a minute or two, depending on their flow. Oh, why can I not change screen? Oh, there we go. And last but not least, that's not one we really want to see that often, is it? We don't really want to see these flat lines. So that's asystole. Unfortunately, this patient is dead. So there's the references that I've used for tonight's slow. So this is what we're going to work at. So we've been working towards this. We've put together 5 shows for this. And this is the understanding of an ECG. After watching these 5, I'm hoping you understand as a pre-hospital clinician, you can go out there and understand what these wiggly lines are saying to you. But does that actually help you resolve the problem in a pre-hospital setting? Well, tips and tricks. I'm going to be putting over, never miss, I don't know why I put it like that, an unwell ECG. We're going to be looking at a systematic approach to rhythm strips and 12-lead ECGs. We're going to be identifying when it goes wrong. We're going to be talking about treatment plans for a pre-hospital clinician, and also a little bit about in-hospital treatment, just because that could change your triage option of which hospital you want to go to, okay? And also I'm going to be giving you a double A4 slide of helpful tips. Little things, little reminders, little joggers, just to remind you, should I be looking at this? Should I be looking at something else? And at the moment, we're coining it for the 18th of June. It's going to be confirmed. I'm just waiting for Andrew to get back just to make sure it's not clashing with something else, but it looks like it's going to be the 18th of June. And it's going to be about 4 hours long. I believe there is an additional cost to it. I think it's about the price of a beer. Come along. I say it's about 4.5 hours, and I guarantee you at the end of it, you will never miss an unwell ECG. You'll understand roughly what nearly all of them are doing, and there's a handful of ECGs out there that you're going to rush to hospital, and the consultants at the A&E department's going to go, honestly, you've brought me this? And so I'd rather that happen than you leave a patient at home with a slightly wonky ECG, okay? So 18th of June.
Hi, I'm Stephanie from CPD Me, and welcome to our webinars. Taking part in our great CPD webinars is an excellent way to learn new skills and knowledge in an informal way, either whilst at work, relaxing at home, or maybe enjoying some downtime in the park. Our webinars are designed to support our learning community, to work and learn in a relaxed and informal environment. And the great thing is, if you're a member of CPD Me, you can replay and watch these back whenever you like. Registering for a webinar allows you to attend the live event and interact with other viewers online, sharing both learning and links. Don't worry if you can't make the live broadcast because you're running out of time or get a late job. Simply register and we'll email you a fully edited copy of the broadcast the following day. Members of CPD Me receive a free CPD certificate for watching both live broadcasts as well as watching previous webinars. Premium members also have access to a personal CPD dashboard that contains priority booking for all our live webinars, plus over 500 CPD webinars and seminars on demand to watch whenever you choose, with automated CPD certificates. You can always purchase a CPD certificate if you're not a member, but it is more beneficial for you to join CPD Me and take advantage of all the benefits. One great feature of membership is that you won't have to pay for every certificate, and we will automatically add a copy into a professionally formatted CPD portfolio, accessible via your CPD dashboard for all our mobile apps. Join today, and we'll backdate any webinars that you've watched within the last 14 days. Now is the time to take charge of your CPD. Now is the time to join CPD Me.